Hello, and thank you for your interest in our study. My name is Stephen Balevic. I'm an adult and pediatric rheumatologist at Geeta University and a researcher specializing in clinical pharmacology and drug trials. Over the next few minutes, I'd like to present some background on the target hydroxychloroquine drug levels that have been shown to inhibit the novel coronavirus SARS-CoV-2 in vitro, and data from our study investigating whether these drug levels are even obtainable in patients with rheumatic disease. I'll conclude with what this means for practicing clinicians, as well as current clinical trials. So as we all have experienced, the SARS-CoV-2 virus has caused substantial morbidity and mortality across the globe. Hydroxychloroquine has been shown to inhibit viral replication through several possible mechanisms. But because hydroxychloroquine requires several months to reach steady state, patients receiving long-term treatment eventually achieve higher both blood and tissue concentrations over time. So it's important that we think differently about the drug's potential effectiveness with short-term versus long-term dosing. However, it's unknown whether our current dosing strategies actually achieve these antiviral concentrations. So therefore, our goal was to compare observed hydroxychloroquine concentrations in patients with rheumatic disease to those with reported antiviral activity. And then secondly, we wanted to provide an example of how dosing simulations can be conducted using available pharmacokinetic or PK models and how these can guide dosing for clinical trials. So I'd first like to spend a moment to define the target antiviral concentrations. There have been at least two pivotal in vitro studies, and I'll briefly summarize key points from the first study. So the authors took monkey kidney cells, infected them with SARS-CoV-2 virus for 2 hours. Afterwards, they added hydroxychloroquine containing medium at different concentrations and quantified viral replication. This allowed the investigators to determine the EC50. That is the concentration at 1/2 maximum viral inhibition. So this is a very common measure of drug potency, but as we'll discuss in a moment, may not be the ideal clinical target. Now, with that in mind, the authors found the EC50 was 6.14 micromolars at 24 hours and 0.72 micromolars at 24 hours. So in other words, incubation time and possibly accumulation into cells was important. Now, as clinicians, we need to take these molar concentration targets and transform them into something we can actually work with. And to do that, we use the molecular weight of hydroxychloroquine and correct for protein binding. And when we crunch these numbers, we come up with a total level in plasma of 0.48 milligrams per liter, and that corresponds to that 48-hour EC50, and 4.1 milligrams per liter corresponding to the 24-hour EC50. I'd also like to point out, though, that complete viral inhibition occurs at an even higher target of 6.7 milligrams per liter. And then it's also important to note that there are differences between plasma, serum, and whole blood. We make the case that for SARS-CoV-2, actually measuring hydroxychloroquine concentration in plasma or serum is preferred, and we highlight this in the discussion of our manuscript. Now that we define target concentrations, we evaluated 3 data sources to determine whether patients with rheumatic disease routinely obtain these targets. These 3 sources allowed us to characterize average drug levels across a wide range of patients with rheumatic disease. And the results of our first name is presented in this table. So focus your attention to this highest dose group of 400 milligrams daily, here highlighted in yellow. We have here the average hydroxychloroquine levels observed in the study, along with the standard deviation. We found that the average levels were below the lowest target exposure, so here highlighted in red, in all studies. However, consistent with the wide variability in hydroxychloroquine pharmacokinetics, we do see that a small proportion of patients can reach or exceed this lowest EC50 target. Now, importantly, assuming the highest EC50, all studies had approximately 1/10 or less the required exposure for viral inhibition. Now, the study also suggests that no patients were able to achieve the concentrations needed for complete viral inhibition. And so next, we leveraged a published pharmacokinetic model of pregnant women with rheumatic disease and conducted dosing simulations using one of several regimens being tested for COVID-19. So for this abstract, though, I'll focus on just the last two dosage regimens. The results of our dosing simulations are noted in these figures. And just to orient you for a moment, the y-axis here is hydroxychloroquine concentration, and x-axis is time in hours. This thick black line in the middle is the median drug concentrations for this simulated dose. The dashed lines here are the 95th and 5th percentile. This blue dashed line in the middle is the lowest EC50 target. And this red line is the surrogate sort of ceiling for safety. And this was derived from the clinical study that did the PK modeling. And so we can interpret this data as follows. So for a pregnant woman already on long-term hydroxychloroquine at a dosage of 400 milligrams a day, increasing that dose to 600 milligrams actually would obtain a peak or Cmax target concentration after the first dose, and that's seen here, and then average concentrations after the second dose. However, mothers who continue the standard of care dosing of 400 milligrams once a day would actually not achieve median concentrations. So the modeling also supports that despite using loading doses of hydroxychloroquine, no patients are able to obtain the levels needed for the higher EC50 or for complete viral inhibition. So then, in summary, we found that the average patient with rheumatic disease, including children, pregnant adults, and non-pregnant adults, are unlikely to obtain the total serum or plasma concentration shown to inhibit SARS-CoV-2 in vitro. The data therefore suggests that current hydroxychloroquine dosing strategies are unlikely to be effective in the setting of SARS-CoV-2 viremia. So this is where the serum most closely mirrors what they did in the in vitro study. However, I think important to note that our data does not entirely preclude a potential benefit for hydroxychloroquine in the setting of COVID-19. So first, hydroxychloroquine may have antithrombotic and anti-inflammatory benefits, and these may be mediated at different target concentrations. Second, intracellular lung concentrations may be critical for the drug's potential antiviral effect. And studies in rats suggest that the lung concentrations are several hundred times higher than in plasma. However, because hydroxychloroquine accumulates in the lungs over several months, it may be the duration of therapy as opposed to the dose that's really key to understanding its potential in COVID-19. So ultimately, our study really highlights that well-designed clinical trials are urgently needed to characterize efficacy, mechanism of action, and goal concentrations for hydroxychloroquine in target tissues before any specific dosing adjustment can be recommended. And I think rheumatologists are very well poised to lead these studies. So with that in mind, on behalf of the authors, I'd like to acknowledge our funding sources and thank our collaborators. I've also listed here several key references. So please check out our article at the Journal of Rheumatology and feel free to email me with any comments or questions. And again, thank you very much for your time. Have a great day.